like to start. Can we have some quiet, please, gentlemen? Thank you.
Okay. Well, I'll comment on the telemedicine Skype interface because we went through this. I talked a little bit about it in that opening lecture, but we also dealt with this in Oklahoma. Was how do we set up and try to accommodate hyperbaric oxygen therapy in a rural setting? And the main point is that it boils down to what the legal situation is in your state. State law determines who is considered a licensed professional to be able to prescribe hyperbaric oxygen therapy, operate a chamber, get the physician component, which the technical component of reimbursement is also based upon the attendance. So depending on that, still the good medical practices are that you have to have somebody there who is able to at least respond to an emergency and handle an emergency. So you can have a remote person potentially monitoring by Skype, by interface, but there still has to be somebody there in case of emergency. And those issues, though, are separate from the evaluation and management component, which, someone needs to be seeing the patient and doing all those GMP documentations that we talked about, and then prescribing it and so on. So if it meets state law and you can do all those things and still have good medical practices, then everything is good.
Thank you, Dr. Harch. Steve, would you like to say a few quick words, please?
My role in this industry is primarily on the equipment side, but I'm also involved in the research side. So I'll be happy to respond to any questions in those areas.
Thank you. Adam?
Well, I guess I would just ask to talk a little about the patient charting, and I usually take a pretty comprehensive intake. Being a naturopathic doc, I have to look at a lot of different aspects of what's going on in the patient case, and all the way from way back in medical school, my handwriting went down the tank, or I never wrote my charts out because I'd look over and say, what was that? What did I say? So I always did it. I typed it out, and what I actually asked the patient to do is I asked them to give me a written history, detailed written history. Type it up, please. Email it in so we have it ahead of time. And I find that's very helpful because it allows me to go through with them what they said. And usually they, of course, forget things, and we're then able to go more in depth. I spent about 2 hours in an intake. We're documenting what's happened out their history in chronological order, and some things may come up like, whoa, hey, you had TB, you had concussive injuries. See, that can show up in possibly some other aspect of what we're looking to treat the case. And then I do further testing. We have different types of testing methods, and EEG is one of them, and as well as other cognitive tests, if need be, blood tests. Refer them out to other practitioners, and sometimes as a hyperbaric doc, if I think there may be something that raises a flag for me, for instance, a pulmonary involvement, I may say, hey, I'm sending you to radiology for an x-ray, or I'm going to send you a pulmonologist. I want a clearance from them first. So you have to document it. As far as documenting during sessions, we're also, again, keeping that record within our medical charting system, so we're able to see what goes on, and the technician will make notes about different occurrences if there were any complications that would make us, for instance, call out Reimers. We've had a couple things in the chamber, and they said, all right, we're shutting that down until Reimers can come out.
Thank you, Dr. Breiner. Okay, everybody, the floor is yours. So, under the subject matters, I hope you have questions, and they're waiting for them. So now is the opportunity. Do I see a hand? I see 2 hands. I'll take those from here. Thank you.
My question is for Dr. Harch. Dr. Harch, as you know, the DSM-5 is now out. That's the Diagnostic and Statistical Manual of Mental Disorders. And in that document, you would find post-traumatic stress listed, as well as not TBI per se, but I guess it comes under the heading of post-concussion syndrome. The significance of that is that they are considered mental disorders under the framework of that document. I'm wondering how we are going to get ourselves in a position to be able to treat a mental injury, a physical injury to the brain, if you will, when these things are being diagnosed under that manual.
That's been the chronic problem. Usually in medicine, when we cannot explain something biologically, they have been conveniently put in a psychiatric category. And you can look at autism as one of the best examples. All of the information on autism is one of a biological injury. Many different causes. Structural imaging has shown abnormality in the children. They're born, many of them have a disproportionate head size. There are just many, many things that underscore biological injury. However, it has never been understood. And the characterization of cancer was back in, I believe, the 40s, 43 or 47. And what you see is the behavior and the other problems. So where did it end up? In the DSM 1, 2, 3, 4, and now 5. So the only thing that we can do to combat that, unfortunately, or maybe fortunately, is this massive public awareness that's now happening. Through football concussions, through the wars in Iraq and Afghanistan, the massive numbers of injured veterans that have come back has now raised the awareness to where unequivocally everyone is now appreciating that traumatic brain injury is an organic injury. And persistent post-concussion, which we used to always say, if 85% got better, the other 15%, what's wrong with you? Well, what's wrong with me is you have a concussion and aware of loss and so on. Now we're to the point where really everybody has loss. And as Dr. Hipskin's slide that was put up there is actually the picture from the Bigler article on loss of reserve capacity. That is almost a carbon copy. It was in 2013 of the graph I've been drawing for patients who come in the clinic for now the better part of 15 years. And what happens is we all start the race of life at birth with tremendous reserve capacity, the ability to absorb insults. And if we take our dementia line, we gradually come down to that. By the end of life at 80 years old, most of us are now cognitively a little bit off. Every insult of the brain, however, does not bring you back to your set point. You lose a little reserve capacity. And what is considered normal aging, drinking, smoking, maybe some brawling, a head injury here or there, in fact, all of those have compromised your reserve capacity. And we're now realizing that you run out of gas earlier. The only thing that's been able to restore reserve capacity is hyperbaric oxygen. So what can we do to combat it? It's what we're doing right here, and it's all this public awareness and standing up and continuing to show these pictures, the data, and so on. And I think we're to the threshold now where people appreciate that this is no longer a psychiatric diagnosis.
I would like to add something to that. I've been involved, as Paul, I think he said, in the effort to get hyperbaric oxygen therapy into play for combat casualty and brain injury for about 8 years now. And a couple things have come out of that picture. When we first started with this, you mentioned that we're going to try to do something about traumatic brain injury. In the same sentence, we're violating what had been two mantras. Mantra number one, that goes back to the invention of gunpowder, was that if a person went into battle and came out with no holes in their body, but their head didn't work, that they were somehow mentally defective. They didn't have the right stuff, etc., etc. You've heard all the labels. That's mantra number one. We come on and say, no, this is a real physical injury. Well, mantra number two, that goes back a couple hundred years, is, well, everybody knows there's nothing to do about a brain injury, so why bother? Well, then we say, okay, no, it's a real physical injury and we can fix it. So we violated two mantras in the same sentence. And, well, they said, guys, there's the door. Let me help you. Now, that's issue number one. That's easing a little bit. But the other thing that is going on here is this is more than just a medical question. This is also a political question. Because when we're looking at the numbers that we're talking about, and my daughter and I have done quite a little bit of digging on this, we're talking about a reallocation of resources that is absolutely unbelievable in scope and size. And that isn't going to happen unless the political establishment is on board and gets the resources put in the right direction. It's easier at the state level than it is at the federal level, because at the state level, the agencies that get to pay for what happens if you don't treat these guys, and the agency that has to pay for them, are sort of in the same building, maybe even across the hall. At the federal level, you got the Defense Department over here and Health and Human Services over there that we talk to. Unless somebody at the top of the pile changes the budget allocation and makes it so that the people that pay for this have some stake in the outcome, it's going to be a tough sell.
Thank you, Steve. Thank you, Dr. Harch. Dr. Breiner, do you need to add anything further on that, or are we ready to move on to the next question?
Well, just medicine is wrought with politics. A lot of egos.
Thank you. Okay, we have our next question, gentlemen.
Hi, this question is for the entire panel. In terms of patient safety, what would you suggest is the minimum training for the tech or person that's running the chamber?
It should be going through a CHT course, number one, top thing to say.
I vote for an EMT level training as the basic minimum.
Steve, do you want mine?
What we do, we sometimes get called to put hyperbaric centers in places where there's not much residual talent. What we typically do is go looking for somebody who is on a police or fire dive rescue team and start with that. The EMT training, to take one of those people and spin them up into a chamber operator is a very short process because they understand all the basic science. But you need somebody that, to start with, that has had some sort of training in diving physiology and the fundamental science of pressure.
Thank you for that question. We have our next one here.
Thank you. Relates to the previous question, and I think for the whole panel regarding patient safety and good medical practice. MDs have decided to go on the right side, I guess, to treat the obvious, increase in all these neurological disorders. And Stephen, I spoke to him as well to help set up facilities for those off-label conditions. Now, correct me if I'm wrong, but I heard in January that from the Clark National Board they would not certify key and hyperbaric technicians to become, is that something that is new, or they would not certify the technicians who work in off-label, facilities for off-label conditions. Is that correct? And that's bizarre.
Yes, they're not renewing licensure, and I believe they're also not, if you're going to be involved with off-label treatment, going to give you a certification. And I just want to point out that's the progression of the whole sequence that I presented yesterday in that lecture. And that this is the continued business approach to hyperbaric medicine in keeping reimbursement at a high level in a hospital-based situation until an off-label indication can be put on a list that's recognized by insurance companies to be reimbursed at that high level. It is restraint of trade, it's anti the practice of medicine, it's everything that is wrong. And that is why we are here for this meeting partly, is that we want to also establish an alternative certification process that is not dependent on diagnosis. In other words, it is not, the FDA does not intervene in the practice of medicine. Remember the slides I put up there? It's very clear on their website what they regulate. If the FDA does not regulate the practice of medicine, can we stand for a technician certifying board dictating who can treat a patient? When you really look at the roots of it, it is all a business issue. And he is tied very, very closely in a business fashion with powers that be that are involved with reimbursement. So the bottom line is you have to establish a competitive alternative that will certify people based on the knowledge, good practice, but not restrict them.
Thank you for that answer. Steve, do you want to add?
I'd like to add a couple aspects to that. Sometimes these decisions are also rooted in a desire to keep hyperbarics in hospitals on the premise that quality is better, safety is better. But my point, one of the things that I say is the people who are likely to have accidents, and this goes even into home care, the people who are likely to have accidents are the people that have been denied access to training. In my experience, and I've done a lot of site installations in a lot of various places, Nobody wants an incident. The people, by and large, are very conscientious. The people that I've seen that have done something stupid and gotten in a newspaper, almost in every case, these are people that for one reason or another were either denied training or didn't access training. They were simply untrained individuals that went ahead and did it anyway. So the more, and our industry's got a safety record that every other field of medicine would envy for. And we really do. But we do that because we train our people, we talk about our problems. And in my view, closing off training in basically chamber operations and chamber safety, which is what CHTs and National Board are all about, to people that don't work in a hospital is simply counterproductive to everything we're trying to do.
Thank you. Dr. Brown, good to move on. We have a question here. I'll take that question shortly. Excuse me, sir.
Thank you. I have a question for any of you. I've heard that protocol should be, and I haven't heard anything here justifying this, but I've heard that the protocol for anyone getting in a hyperbaric chamber should have just a simple chest x-ray within every 6 months. Have any of you ever heard that?
That's the first time I've heard that. But for a lot of people, they originally, years ago in hyperbaric medicine, everybody thought, remember the inflated pulmonary risk, air embolism, spontaneous pneumothorax. Who gets a spontaneous pneumo? It's actually a certain body habitus and genetic makeup of people. It's a very slender, tall individual, low body weight with a narrow AP diameter of the chest. What's associated with that body habitus are blebs at the apex of the lungs. Those are the people who can have a spontaneous rupture of those blebs. How many of those people are we putting in our chambers? It's an exceedingly low risk. So chest x-ray became part of the whole workup. The reality is, I don't even get them anymore unless you have an underlying pulmonary problem, or the children, for instance, had significant lung problems at birth. In which case, if we're worried about scarring or whatever, it's at most a theoretical risk. UTMB Galveston, University of Texas Medical Branch Galveston, where Dr. John Mader, who was past UHMS president, Hyperbaric Oxygen Therapy Committee of the UHMS, etc., practiced for, I'm guessing, I think it's close to 20 years, never got a chest x-ray, screening chest x-ray on people. And that place did not have a big risk and accident profile. So, no, it's not necessary unless you have a reason to do it. Certainly not every 6 months.
Thank you. Anything from the other two members of the panel?
I only order it if needed, or refer them if need be. In only cases that I would think may high risk, but no. I remember I asked Dr. Neubauer that years ago. He said, well, that's ridiculous.
Thank you. We have our next question. We have 10 minutes of questions before we close.
Soap notes. So what's the patient charting that you're giving guidelines? Are you adopting a specific protocol for hyperbaric versus standard medical practice?
No, not necessarily. Just that, someone has to be there in attendance who is supervising it. But when I sign the note, I don't bug the patient every day. How you feeling? How you doing? There's a pressure on it, and they almost feel obligated to tell me, yeah, I'm getting better. I got one to tell them that I'm getting better. And so I leave them alone. I watch them. I look at them. I look at body language, facial expression, etc. And I talk to them periodically just to see how they're doing. The dive sheet, though, we have the text documenting their interaction, the safety things, the typical things about ear clearing, that they're so on. Physician note is one of mainly attendance and no problems. And then any interaction that we do have, we will document that in terms of symptomatology. If things are going wrong, going right, whatever, we're on the right track. But no, it's not a detailed thing. It's just some documentation you want to see. Which leads me to a comment I wanted to make about that. When we are doing off-label, you're under greater scrutiny. And should someone come in, state medical board, a complaint be lodged or whatever, you live and die by your record, because that's what gets put in, and all the verbal exchange is meaningless in a legal document. So you have to keep a good record. Your history and physical, at least have daily dive sheets and some notes about that, periodic notes in addition if you need to. But it is your defense.
Thank you. On charting, gentlemen, on the panel, any further comments to add? Steve?
One thing that's happening in the United States, at least slowly, and this has to do more with reimbursement than anything else, there's a steady movement towards actually having a electronically acquired pressure time profile from the treatment, finding its way into the electronic medical record.
Thank you. We have a question from the back of the room here.
Anyone on the panel, this is related to charting and documentation. Other than a thorough history and physical as the patient is taken in, are there specific things related to hyperbarics that you need to ask the patient and document? And is there an electronic medical record that is being used that's specific to hyperbaric or that is being recommended?
I mean, I have an electronic medical record system, and I just had created my notes and modified them according to, because I use hyperbaric. Well, I will discuss with the patient the possible contraindications and everything, and I go through that with them on a paper that they will sign, but I also note that in the charts, and they sign the paper, I sign the paper, we scan that in, but there's also a part within the electronic medical record where we'll check off if I discussed it with them, so it's kind of redundant documentation. And so I will may go through some of the possible complications and just basic, during the history, if there may be anything that would make a red flag for me. Like I've had a couple of people over the years who had spontaneous pneumothorax as a past history. And you're doing physical exam. Gee, what is that scar doing there? Oh, I used to get these pneumothoraxes. Guess what? You're not going to change. That's all.
Actually, if you pleurodese them, they're okay, because if they do have another pneumothorax, they're limited in terms of degree of collapse. But that's another issue. Well, the standard, there is no standard H&P that I have seen. But when you do the history and physical, what you really should do is be addressing all of the potential risk factors and the things that are going to be on your consent form. So if you've got somebody who has had 6 sets of PE tubes as a kid and has trouble every time they get on a plane, you want to be asking them about this. We ask them about the other risk factors, seizures, of course. Seizures, it's going to be an issue for what kind of dose you're going to give them. Chronic pulmonary conditions, active asthma, this type of stuff. And then there's a list of all of these things you can get from kind of standard hyperbaric medicine text. In terms of an electronic record, I've seen a bunch of them now. I just developed one for us at the university only because we got forced to use this pathetic electronic health record that we're now having to use. I would just encourage you just go through and you identify the risk factors and the other things that you want to address, and you can put it in an electronic format.
Thank you. Steve, anything to add on this one, or are we
No.
good to move?
I'll
I think
pass.
we're still on the charting item. Here we go.
If I could only make a comment, Paul and Steve, you're absolutely correct, but I think that everyone needs to know that CMS, and especially the local intermediaries, are becoming much more definitive in the charting that they're requiring for payment for hyperbaric therapy. So you need to have a start time, leave surface, at depth, time at depth, time to air brake, length of air brake, leaving bottom, and when you get to the surface. And saying that you started at 11 o'clock and finished at 12:10 is not going to cut it anymore. And they are, each one of them, it gets put in and knocked back out, but eventually it's going to stick. And so I think this sort of generalization of 60 minutes at bottom time, not knowing when it started and when it finished, is long gone. That people just have to adapt to the new requirements.
Good point. I'm not trying to say that we're not doing that. His question was about the SOAP note in particular.
Oh, I thought it was about the timing of
No, I thought he mentioned SOAP was a typical SOAP note that we were asking. I was just talking about that documentation. What I was saying is that the tech component of it, and what gets documented, in fact, is all of that. dive time, leave surface, reach depth, stay there, air brake, the timing of it, all of these things, along with other documentation, numbers of treatments, the protocol that you're on, or at least the dive profile and so on. So we have a whole standard sheet with all of that information. And yes, you have to have that on there.
Thank you, Dr. Harch. Gentlemen, anything to add, or are we good? We'll take another question.
I would add to that, they're also asking of progress. What kind of progress the woman's making, if the diabetic woman's making progress, as the patient's condition, mental status, whatever changing. The question that I had was monitoring during the treatment. Do you all recommend routine EKG monitoring or during the dive per se? In recent, we found that increase in heart rate correlates very well for somebody who might be on the verge of having a seizure or does have a seizure as a monitoring tool, and we're very sensitive to that. Number two is, had a patient with absolutely no history having a 12-week run of VTAC the other day, so I wouldn't have known that unless we were monitoring at the time.
Who would like to comment on that?
We never EKG monitor a patient inside the chamber for the typical off-label things that I'm doing. I haven't found it necessary. The only ones where we did this were people who we put in with unstable dysrhythmias, 18, 21-year-olds who had VTAC or VFib, cardiac arrest, and now had an implantable defibrillator. Defibrillators is the one implantable device that the company will hedge on in terms of not giving you a clearance to put in the hyperbaric chamber. Because should there be a spark discharge, they can't tell you that you won't have a spark from the skin surface. Now you can ground them and hope that that works, but they hedge on it and they tell you to get the cardiologist to make the decision. Well, what we do is we put a magnet over it and we disable it. And so in those that have had that type of unstable condition, we'll then monitor them with cardiac, and what we find is their dysrhythmias go way down. The monitoring even is unnecessary. But for the routine patients, unless I've got a problem and a real cardiac issue, no, we don't do it.
Thank you, Dr. Harch. Gentlemen, anything to add? Dr. Breiner, we're good.
No, we're not doing EKGs on patients.
So, we're out of time. It was a fairly short panel discussion. This has been a bit of a pilot for this particular conference. I get the impression from the questions, but it's just me on the outside looking in, that I think you're finding that the panel discussion aspect is a good one. But every one of you has individual comments. That is what your evaluation form is for. We will take the majority and we'll look to that when we do the next conference. So if you have comments to make on these panel discussions, good or bad or ugly, we want to hear about it. At this juncture, I would like to, on behalf of everybody here, thank our three gentlemen for their contribution.